Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Hey listeners, it's August. Wow, time is flying. Hopefully this time next year we'll be gearing up for the usual end-of-year conferences. It's hard to believe it's been 5 months since I last unpacked a suitcase for a business trip. Anyway, I know we're all living it and we're tired of talking about it, so I'll move along. Besides, we have some pretty great articles to share with you from the July-August issue of Modern Optometry here on the ModPod. So the cover focus for the July-August issue was on ocular surface disease, and we chose a great sampling of these articles for this episode. Let's start with a piece on innovations in dry eye treatment by Damon Dierker, Director of Optometric Services at Eye Surgeons of Indiana in Indianapolis. Here's Dr. Dierker with the dirt on what's coming and what's on the horizon.
In the practice of optometry, there are many innovations in development that have the potential to enable eye care providers to deliver care to patients with dry eye more effectively while also improving practice efficiency. This article takes a look at some of these advances. Although it is not new, telemedicine has definitely seen an increase in use and popularity in recent months. Prior to COVID-19, I admit I was naive as to the power of telemedicine in optometry. I was an early adopter of the 4C Home AMD monitoring program, and I continue to advocate for its use for patients with high-risk macular degeneration, but more robust telemedicine and remote monitoring services were lacking in my practice. Our ability to use technology to provide more efficient patient care is accelerating at a rapid rate. Patients enjoy the flexibility of receiving care without an in-office visit. In my practice, dry eye disease and telemedicine have been a great fit thus far. Here are some ways I've recently used telemedicine to enhance patients' outcomes and experience with dry eye disease. We can educate patients about dry eye and available treatment options before their first visit to our office via a video chat or phone call from a staff member of me. The discussion can include self-pay in-office procedures such as intense pulse light and treatment for meibomian gland disease. We can offer a virtual progress check in lieu of an in-office visit 2 to 4 weeks after initiating dry eye disease therapy, which may range from nutraceuticals to prescription therapy to in-office procedures. This gives us an additional opportunity to discuss the chronic and progressive nature of the disease, encourage compliance with prescribed therapies, identify any challenges with obtaining the recommended products, and refine treatment goals and management strategies. An in-office follow-up is typically scheduled after this virtual visit at an appropriate time interval. We can provide selected dry eye disease therapies, for example, nutraceuticals, artificial tears, lid hygiene products, and even prescription therapy in some cases via a virtual consult, then schedule an in-office follow-up visit a few weeks later to refine the diagnosis and treatment plan. There are many effective options that can be safely prescribed via telemedicine because they have few, if any, contraindications. We are only scratching the surface with the power of telemedicine to help manage patients with dry eye disease. I predict that a hybrid approach of periodic in-office visits mixed with virtual follow-ups will be well accepted by patients and will have the potential to lead to similar or improved treatment outcomes. Direct-to-consumer dry eye disease marketing campaigns from pharmaceutical companies will bring awareness of dry eye front and center to our patients, both established and new. We can take advantage of this by creating flexible, versatile protocols to manage these patients while maintaining the standard of care. Next, let's look at some therapies that may be available soon that may affect how we treat patients with dry eye in the future. Chronic inflammation is a key component in the pathogenesis of dry eye. Restasis and Xiidra are FDA-approved anti-inflammatory therapies for dry eye. In addition, topical corticosteroids can elicit potent anti-inflammatory effects, and they are often used for induction therapy and management of acute dry eye flares. Specifically, Lotemax is a corticosteroid that was engineered with the goal of maintaining robust anti-inflammatory activity while minimizing risk of side effects. including elevated intraocular pressure and cataract formation. However, available formulations of loteprednol, etabinate, are not specifically indicated for the treatment of dry eye. Positive results were announced for the phase 3 STRIDE trial, which evaluated KPI-121 for the treatment of dry eye disease. The company plans to commercialize this product under the brand name Isuvis. Compared with placebo, KPI-121, utilizing amplified mucus-penetrating particle technology, demonstrated a statistically significant reduction in ocular discomfort severity from baseline to day 15. Patients with more severe symptoms, which was a predefined subgroup, also showed significant improvement in ocular discomfort severity. If it is approved, KPI-121 could be the first topical steroid with labeling for dry eye flares. The lacrimal functional unit consists of the lacrimal gland, goblet cells, and meibomian glands. Coordination of the LFU helps maintain a healthy ocular surface. The parasympathetic nervous system controls tear film homeostasis partially via the trigeminal nerve. Activation of this pathway can activate all components of the lacrimal functional unit. TrueTear is a handheld intranasal tear neurostimulation device indicated to provide a temporary increase in tear production in adults with dry eye symptoms. In my clinical experience, I have found this novel technology to be effective in selected cases. Unfortunately, this product was recently discontinued. The iTear 100 is an external tear neurostimulation device recently approved by the FDA that applies a small amount of mechanical stimulation to the skin on the outside of the nose to stimulate the external nasal nerve in a few seconds. This activates the trigeminal parasympathetic pathway to stimulate natural tear production. A recently completed 6-month study showed an immediate post-stimulation increase in tear production and an unstimulated increase in basal tear production. There was a corresponding improvement in symptoms, corneal staining, and meibum quality. In the recently completed phase 3 ONSET 2 study, the use of OC01 nasal spray was shown to improve both signs and symptoms of dry eye disease. A greater percentage of the study patients had improved Schirmer score and eye dryness score when treated with either 0.6 milligrams or 1.2 milligram doses of OC01 compared with placebo. Of note, the study population consisted of patients with dry eye symptoms ranging from mild to severe. OC01 is a highly selective nicotinic acetylcholine agonist, preservative-free nasal spray that also activates the trigeminal parasympathetic pathway. A pharmacologic neurostimulation treatment option with a broad indication would be a welcome addition for both primary and adjunctive treatment of dry eye patients. Demodex mites are a common cause of blepharitis, implicated in approximately 45% of chronic cases. The clinical finding of cylindrical dandruff is pathognomonic. In one study, 100% of lashes with cylindrical dandruff were found to have Demodex mites. Standard treatments include lid hygiene products containing tea tree oil and oral ivermectin. A new topical formulation that causes paralysis and death of Demodex mites is under investigation. Phase 2 studies have shown that a 6-week course of twice daily dosing of TP03 cured 70 to 80% of patients. A phase 2B/3 trial is underway. If approved, TP03 would likely be the first prescription agent specifically indicated for the treatment of Demodex blepharitis. When I think about the future of managing patients with dry eye, I envision a hybrid model of patient visits with both in-office evaluation and virtual follow-up visits. This care model, along with the addition of new therapeutic options, will hopefully allow us to provide more efficient and effective treatment for a greater number of patients with dry eye disease.
As any good clinician knows, dry eye can be a symptom of systemic conditions. Next up, Seema Nanda, CEO and Director of Nanda Dry Eye and Vision Institute in Houston, Texas, talks about Sjögren syndrome and how secondary forms of Sjögren can be associated with other autoimmune diseases, making it important to differentiate between non-Sjögren and Sjögren syndrome dry eye disease. Ready to learn some tips for making a differential diagnosis?
Dry eye disease invokes an image of red, burning, irritated eyes that become noticeable in individuals who actively use their digital devices, live in low humidity environments, or take antihistamines for their never-ending allergies. These scenarios, in addition to advanced age, may increase one's risk for developing dry eye disease, a condition in which triggers can be exacerbated by external factors. This condition is referred to as non-Sjögren's dry eye disease. Its effects can be mitigated through the use of lubricants, anti-inflammatory medications, and the avoidance of the causative agent. Dry eye disease can also occur when an individual's own body attacks moisture-producing glands. In this case, although the symptoms are similar, the cause is internal and is recognized by an autoimmune condition known as Sjögren syndrome. This systemic inflammatory disease primarily affects the salivary and lacrimal glands and may exist as a primary disorder. There are also secondary forms of Sjögren's associated with other autoimmune diseases such as rheumatoid arthritis, systemic lupus erythematosus, or systemic sclerosis. Therefore, it is important to differentiate non-Sjögren's from Sjögren's disease in order to assist the diagnosis of these seemingly similar syndromes. What is dry eye? The definition of dry eye disease has evolved greatly as we have developed a better understanding of what the mechanism of tear production and the composition of the tear film. In the TFOS DEWS 2 report, or Tear Film and Ocular Surface Society Dry Eye Workshop Report number 2, dry eye disease was redefined as, quote, a multifactorial disease of the ocular surface characterized by a loss of homeostasis in the tear film and accompanied by ocular symptoms, in which the tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles, unquote. Factors contributing to dry eye come from 3 sources: the meibomian glands, the goblet cells on the conjunctival surface, and the lacrimal glands. Each one produces a distinct layer of tear film that keeps the eye moist and functional for good vision and comfort. The meibomian glands produce meibum, the top lipid layer of the tear film, composed of several types of fats needed to keep that layer in balance. One of the key components of the meibum is triglycerides. In patients with meibomian gland dysfunction, the triglycerides are converted from a diglyceride and monoglyceride by the enzyme lipase. This transforms the meibum from a thin serous oil to a thicker gelatinous lard. This conversion is also known as inspissation and leads to deterioration of the tear film, causing fluctuations and blurring of the patient's vision. In a non-Sjögren's dry eye, the tear film breakup time decreases when the lipid layer becomes compromised through the aging process, compounded by a poor diet with saturated fat. The oral consumption of a gamma-linoleic acid, or GLA, and an alpha-linoleic acid, or ALA, fatty acids found in these foods such as salmon and nuts, or in supplements such as Hydro Eyes, can help prevent this deterioration of the tear film. One can replenish the diminishing tear film by combining the unique omega fatty acid GLA found in black currant seed oil with EPA and DHA, or eicosapentaenoic acid and docosahexaenoic acid. This is from an ultra-pure USP verified fish oil. This blend assists in blocking the formation of pro-inflammatory prostaglandins while stimulating the production of anti-inflammatory prostaglandins. This GLA works through a metabolite, DHGLA, or dihomogammalinoleic acid, to stimulate the tear-specific prostaglandin E1. This reduces inflammation and supports the tear production. Consequently, this adjunctive therapy containing the GLA can help reduce inflammation and maintain the corneal smoothness while improving dry eye disease symptoms. According to the Sjögren's Foundation, 90% of patients with Sjögren's are women over 40, who also report having disturbed sleep, depressed mood, and fatigue, all of which lead to the development of meibomian gland dysfunction. However, in patients with Sjögren's, the meibomian glands are not affected in the beginning, but rather they deteriorate at least 3 years after onset of the symptoms. This delay may be attributed to the damage over time of the lacrimal gland, causing the decrease in the tear film volume, thereby deteriorating the meibomian glands. Evaporative dry eye disease in Sjögren's may also be related to immune-mediated androgen deficiency, cytokine-induced disruption of neural meibomian gland epithelial cell interactions, and secondary aqueous deficiency. More research is needed to fully understand the etiology of MGD in patients with Sjögren's. The goblet cells assist in the production of the innermost layer of the tear film, the mucin layer, which provides the protective coating to the corneal epithelium. In a non-Sjögren's dry eye disease, loss of the goblet cells is an early cause of the dry eye. Reduction of mucin contributes to the tear film instability and loss of homeostasis due to an increased level of inflammatory cytokines. When this damage occurs, the mucin may be sparse and lead to filaments on the corneal surface. If patients with Sjögren's, by contrast, the body attacks its own exocrine glands. So while the white blood cells infiltrate the tear glands, this leads to a decrease in the tear production. The tear fluid shows reduced levels of goblet cell-specific mucin protein, also known as MUC5AC or MUC5AC. Deficiency of this protein in the tears is one of the mechanisms responsible for the tear film instability in Sjögren's. Staining of the conjunctival surface with lissamine green may aid in your diagnosis. Moreover, inadequacy of that mucin layer may increase the symptoms of pain and burning associated with dry eye and requires stronger mitigating factors than just the use of lubricating artificial tears alone. A viable treatment option may be to incorporate cyclosporin ophthalmic emulsion 0.05% Restasis or 0.09% in Cequa, as these drops are immunosuppressive agents and increase goblet cell density and production of the immunoregulator factor TGF-beta 2 in the bulbar conch. Patients' symptoms should begin to subside with continued use twice daily of these drops. It may take time, but will help. The lacrimal glands now produce the aqueous layer, which is the bulk of the tear film sandwiched between the lipid and the mucin layers. Severity of symptoms increases as aqueous production decreases, while infiltrative cytokines rise with age and other external factors. Use of computers and systemic medications amid a dry, windy environment can intensify non-Sjögren's. Yet, in Sjögren's syndrome, dry eye disease is a comorbidity of the autoimmune disease, in which circulating autoantibodies are produced by B lymphocytic cells. Antibodies play a role in the initiation of the immune attack against the lacrimal gland. The most commonly detected antibodies are SSA or Rho and SSB or La. These are the hallmarks for the diagnosis. In addition, an upward surge of cytokines can further inflame the lacrimal glands, impairing their function. No single test to confirm diagnosis of Sjögren's exists. Optometrists should work in tandem with rheumatologists and even dentists to conduct tests and inquire about patients' signs to aid in identification. Eye care practitioners can test for the inflammatory tear marker matrix metallopeptidase 9 found in inflammatory and stain with lissamine green to detect devitalized tissue. Rheumatologists can perform a blood workup aimed at the autoantibody testing for SSA or Rho and SSB or La. The assays available at present will not confirm 100% autoantibody sensitivity. However, the positivity rate is reasonably significant at 70% for SSA and 40% for SSB. Plus, A dentist can evaluate salivary flow and gland biopsy to analyze lymphocyte infiltration to corroborate the findings. Ultimately, early diagnosis and appropriate treatment are crucial in improving the quality of life in individuals with Sjögren syndrome. Symptoms develop gradually and can mimic other conditions, including menopause, lupus, rheumatoid arthritis, and chronic fatigue syndrome. Sjögren syndrome is often underdiagnosed or misdiagnosed and requires a multidisciplinary approach in order to be properly identified. It can take up to 3 years before recognizable onset of symptoms, including dry eyes, dry mouth, and dry hands, which, together with the aid of MMP9 inflammatory testing and lissamine green staining, can assist the optometrist in differentiation of this cryptic condition.
Did you catch the part where Dr. Nanda mentioned that of patients with Sjögren syndrome, 90% are women 40 years of age or older who report having disturbed sleep, depressed mood, and fatigue, all of which lead to the development of meibomian gland disease? Great, hold on to that thought. The Mod Pod will be back after a quick break.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Okay, now back to the topic of ocular surface disease in women. If this interests you, then this next article is for you. Tracy Doll, who is an assistant professor and coordinator for Pacific Dry Eye Solutions at Pacific University College of Optometry in Forest Grove, Oregon, examines the changing ocular surface in women through the stages of life. Have a listen.
This article focuses on the concept of biological sex and not gender. Sex is a classification given to biological organisms based on their chromosomal makeup and reproductive organs. Gender refers rather to an individual's self-representation as male, female, or other, reflected as societal and cultural characteristics given to behavior. For the purposes of this article, the terms female, male, woman, and man will reference sex characteristics, which play a crucial role in ocular surface dryness. Strong epidemiologic evidence indicates that the female sex has a higher predilection for ocular surface dryness. Risk factors for ocular surface dryness change and compound over a lifetime. Even changes in hormones can trigger flare-ups. But a firm understanding of key milestones in ocular surface dryness over the course of a woman's lifetime can guide eye care providers in recognizing when their female patients may need ocular surface support. Milestone 1. Maturity. The ocular surface was made to be partially regulated by hormones. The cornea, conjunctiva, and tear glands all have receptors specific to testosterone, estrogen, and progesterone. The sex hormones act locally are not all primarily sourced from the ovaries and testes, but are also synthesized in the ocular tissues. This endocrine system modifies the adrenal sex steroid precursor, DHA, to generate estrogen and testosterone. The adrenal gland also supplies progesterone. The difference in the incidence of ocular surface dryness between men and women is largely attributed to the difference in levels and processing of hormone levels between the sexes. Testosterone, a member of the androgen family, is secreted in higher levels in men. Testosterone has a positive effect on the ocular surface, mediating actions through alterations in gene activity. Conversely, estrogens are produced in much higher levels in premenopausal women, and the effects of estrogen on the ocular surface are varied. Estrogens have the largest effect on ocular surface dryness by interrupting the binding of the supportive testosterone. These two hormones have reverse actions. To a lesser extent, estrogens and progesterone have direct effects on the ocular surface itself. Testosterone can increase the quantity of tear secretions and the quality of tear secretions from the lacrimal, meibomian, and goblet cells. Testosterone will suppress inflammation of both the lacrimal and meibomian glands, and it also downregulates hyperkeratinization of epithelial cells. Estrogen's effect on the ocular surface are different. They help epithelial cells in the cornea reach maturation. They can also stimulate goblet cell secretions. However, unfortunately, they do interrupt the binding of androgens, decrease corneal sensitivity, and decrease the level of meibomian and lacrimal gland secretions. Progesterone is probably the least studied of the three hormones. What we do know is that it has the potential to decrease meibomian gland secretions. At this point, there are unknown and conflicting reports in the literature on the effects of the lacrimal gland and the goblet cells with progesterone. Milestone number 2, pregnancy. Pregnancy can elevate the risk for ocular surface dryness. Increases in estrogen, progesterone, and prolactin released from the placental tissues, ovaries, and pituitary gland are associated with temporary ocular surface dryness. Ocular surface changes can occur throughout the 40-week pregnancy time span, but they mostly arise in the third trimester when hormone levels are the highest. Animal models have demonstrated that higher levels of estrogen, progesterone, and prolactin are associated with an increase in tissue remodeling and pro-inflammatory cytokine circulation. Ocular surface dryness can also be exacerbated in those with morning sickness. Both vomiting and the use of anti-nausea medications have ocular surface drying effects because of dehydration. Now, most ocular surface changes will go away within 3 months of giving birth, as pregnancy hormones dissipate and those mild corneal deviations resolve. It is important to educate patients that any alterations made to glasses or contact lens prescriptions during pregnancy are unlikely to be permanent. If a patient's refractive changes, usually a myopic shift, are deemed unsafe for driving, providing a small supply of daily contact lenses may help. But should contact lens intolerance occur, a temporary change in the patient's spectacle lenses may be preferable. Referrals for refractive surgery should be postponed, along with any kind of prognosis for corneal ectasias, keratoconus, and non-urgent glaucoma, until the cornea stabilizes postpartum. Treatments for ocular surface dryness must be balanced with doing no harm to the growing baby. Palliative and mechanical choices are often favored by both patients and practitioners during pregnancy. Non-preserved artificial tears can offer safe and temporary relief. And meibomian gland expression with vector thermal pulsation or a handheld LED is not directly contraindicated, but you should know it has not been studied in pregnant women. In the event that topical pharmaceuticals such as a topical steroid, cyclosporin, or an anti-allergy drops are needed to help combat the corneal edema or irritation, punctal occlusion should be performed to limit systemic absorption. None of the aforementioned topical drops exceed the FDA's pregnancy category C, wherein the potential benefits may justify the use of the drug in pregnant women despite the potential risks. So treating patients with ocular surface dryness who are pregnant can be achieved. And finally, we hit milestone number 3, menopause. Menopause is a necessary female milestone that is the result of the natural aging of the ovaries. It is a 2 to 8 year process that marks the end of the reproductive ability and is signified by cessation of the menstrual cycle for 12 or more months. Women usually reach menopause between the ages of 40 and 55 years old. The ovaries stop secretion of estrogen and testosterone. Small amounts of these hormones will still be produced locally within the peripheral tissues by modifying the DHA from the adrenal glands. By the onset of menopause, age-related decreases in DHA and progesterone have already occurred, with a loss of 60% from peak secretion. This combined loss of DHEA from the pituitary gland and hormones from the ovaries has been correlated with a worsening of ocular surface dryness and symptoms. A loss of androgens that results in tear deficiency seems to be a sex-linked condition, as androgen deficiency in men does not reduce tear secretion. Hormone replacement therapy is often prescribed to women experiencing symptoms from the menopausal transition. So, for example, hot flashes, night sweats, uterine bleeding, mood changes, sleep disturbances, and sexual dysfunction. Hormone replacement therapy can be administered orally or through the use of transdermal patches or creams, and it can be estrogen only or estrogen mixed with testosterone. Now, the effects of hormone replacement therapy in the ocular surface dryness described in the clinical research literature is mixed. Some data indicates that hormone replacement is helpful, whereas other studies indicate that hormone replacement therapy is a risk factor for ocular surface dryness. The variability in the research is thought to come from differences in route and location of administration, so topical versus oral, skin versus ocular, concentration levels, and the use of a placebo or non-placebo controls. and the use of estrogen or estrogen plus progesterone. Further controlled prospective studies are required to determine the true impact of hormone replacement therapy on the ocular surface. Although there is not enough data to recommend HRT as a treatment for menopausal or postmenopausal ocular surface dryness, eye care providers can counsel patients that hormone replacement can potentially improve or worsen ocular surface dryness symptoms. Because testosterone production also decreases during menopause, topical testosterone application has been studied as a treatment for meibomian gland dysfunction. A phase 2 clinical trial by Schiffman et al. Demonstrated improvements in meibomian gland secretion and ocular comfort with application of a 0.03% testosterone ophthalmic solution. No studies past phase 2 have been initiated. Should signs and symptoms of ocular surface dryness worsen during a patient's menopausal transition, it may be time to move from more palliative therapies, like artificial tears, to anti-inflammatory interventions. These may include topical prescriptions such as cyclosporin ophthalmic emulsion 0.05% or 0.09% now, or lifitegrast ophthalmic solution 5%. Amniotic membranes, materials, membranes or drops, or autologous serum. A more frequent follow-up schedule or the use of mechanical therapies for meibomian gland dysfunction may also be indicated. Now watch your milestones. Eye care practitioners should be aware that women's lifetime milestones of pregnancy and menopause can exacerbate or worsen signs and symptoms of ocular surface dryness. Patient intake forms and questionnaires can help doctors pinpoint patients' relationships to these life shifts. Ocular surface dryness doesn't have to make these transitions more difficult. Modern therapies include new and updated options that can help patients at all stages of life.
Our fourth and final article isn't on ocular surface disease, but it's sure to be a crowd pleaser. We have our Up Close column, in which Mod's associate editor Katie Herman interviews a different optometrist for each issue. This time around, Katie has some questions for Leslie Odell, the chief medical editor of Modern Optometry and the regional clinical director of Medical Optometry America in York, Pennsylvania.
What drew you to optometry?
Helping others. I always knew I wanted to do something involving caring for other people. I began my college career thinking I wanted to do this through teaching, but quickly learned that elementary education wasn't for me. Medicine seemed to be more of what I should focus on, so I switched to a biology major with a pre-med focus and even earned early acceptance to Thomas Jefferson Medical School. In my junior year of college, optometry was recommended to me by my high school guidance counselor, who is now my father-in-law, and my focus became clear. Optometry allows me to help others while fulfilling my love of learning.
You are well known for your expertise in dry eye. What led you to this subspecialty?
Chance. Like many of my peers who developed a passion for dry eye, early on my interest was driven by necessity. Medications were limited and knowledge was slowly growing, but one thing was clear. These patients needed our attention. I was working in a surgical practice and treating a lot of post-surgical dry eye disease. When you're able to make a difference in the life of a patient, it is an overwhelmingly rewarding feeling. I also love to teach others and to help them develop their passions to treat dry eye disease.
What is a typical day at the office like for you?
Diverse. I'm in the process of starting a new practice as one of the first Medical Optometry America locations in the country. One day I may be collaborating with brilliant ODs and MDs on best practices and critical guidelines. Later that same day I might be talking about office layout or decor. On other days I'll be working on a variety of initiatives including staffing, selecting EMR, systems, marketing, and more.
What keeps you busy, fulfilled, and passionate?
Life. My family is my first priority, and I love to be with my husband and kids. We enjoy being outdoors, and the beach is one of our favorite vacation spots.
Are there any particular advantages or challenges to being a woman in the optometric profession?
The name game. Over the years, I have experienced some challenges, but it's hard to say whether it's just related to my gender or rather my youth. Sometimes patients will refer to me by my first name, even if I introduce myself as Dr. Odell. I used to get many questions about whether I was old enough to be the doctor. Fortunately, the gray hairs and fine lines of my 40s are making those questions more infrequent. I've even been told by a 92-year-old female patient that women aren't as smart as men. I believe time changes all things, and over the years of my career, I have seen these biases change and lessen.
What goals do you have, both personally and professionally, for the next 3 years?
Disruption. Optometry is in the midst of a transformation, with the shift on medical optometric care becoming absolutely essential. I was drawn to Medical Optometry America and that model because I truly believe it is the future of our profession. We need to continue to evolve as a profession and collaborate more to meet patient needs. The next 3 years will be exciting at a challenging time, and I am honored to be playing a key role in the transformation of our field.
What are some of your hobbies and interests outside of work?
Staying active. This pretty much sums up my life outside of work. I love being again with my husband and children, Anna, who's 12, and William, who's 9. Exploring the world through their eyes is something I love to experience. As a family, our new interest is biking, and we've had some time to explore various trails here in Pennsylvania and northern Maryland over the spring and summer.
That's it for this episode. Come back again next month to hear our article selections from the September issue. Listen for free on Spotify, Apple Podcasts, or Google Podcasts. In the meantime, follow us on Instagram, LinkedIn, Facebook, or Twitter, and tell a friend. If you have any feedback or ideas, we'd love to hear from you. Email us at modernod@bmctoday.com. Until next time, stay healthy.